Hi, and welcome to Resiliency Awareness. I'm your host, Rick Campos. So, what are we going to be talking about today? Today, we'll be discussing first responders' experience rates, their rates of depression, post traumatic stress disorder, also known as PTSD, and other mental health issues that may lead to suicidal ideations, suicide attempts, and death by suicide in far greater percentages than the general population. Now, not only does the exposure to acute traumatic events play a role in the origin of these disorders, but occupational and environmental conditions where first responders work on a regular basis are also a significant contributing factor in mental health. So, what are we going to cover in this course? Well, in this course, we are going to cover common exposures for first responders, the contribution of these exposures to mental health issues, common mental health issues in first responders, suicide statistics, mental health treatment, and long term care for traumatic events. Common exposures for first responders and their contribution to mental health issues. Now, first responders face many occupational conditions. Now, these occupational conditions have been shown to be associated with altered moods and feelings of well being. Many of these conditions may compromise individuals' resilience and increase the risk of PTSD and depression when first responders are exposed to acute traumatic events. So, what are some of these conditions that can lead us to this? Occupational conditions may include heat, smoke, sleep restriction, physical injury, heavy physical exertion, physically demanding settings, personal danger, and environmental and occupational stressors. Now, on this list, I'm going to pick out a couple that really stand out to me. One is sleep restriction. Now, it doesn't matter if you run one call a year or millions of calls a year. As a first responder, we are designed to get ready for the next call. And just like if you're sitting down and you're awaiting someone to come around the corner, you're anticipating something else, same as a first responder. And with this being said, we are truly never at rest. How many times have you sat down just about to eat shift meal and the tones go off for a structure fire? Or you're right about to lay your head down after a long shift and you get toned out for chest pain. We're always awaiting that next call. So our bodies are never really truly at rest. Physical injury. Now, this is a very broad topic and it encapsulates so many things that we do as first responders. It could be anything from getting out of the rig on a busy freeway, taking a gurney down a flight of stairs, using the stair chair. Things of that nature can give us into some physical injury. And once we have that physical injury, it may be a while before we get back on shift. So, along with that, many different issues go along with that, such as, am I going to pay my bills? Will I get workman's comp for this? So on and so forth. Many of those little different intricacies that go along with physical injury start to play into our minds, and that can lead us into a mental health issue. Critical events are incidents that may have stressful impact enough to overwhelm an individual's sense of control, connections, and meaning in his or her life. Studies have shown that proximity, duration, and intensity of the exposure are the most significant predictors of the first responder's physical and mental health symptoms. Now, a few years ago, I responded to a motor vehicle accident. I was a paramedic on a truck company and a local fire department. We responded to an MVA with a vehicle rollover. We show up on scene. I get out of my rig, and a battalion chief comes to me and he says, "Are you a medic?" And I say, "Yes, sir." He says, "Now come with me." Now, when a battalion chief talks to you like that, you listen, right? So I followed him to this RV where I saw two little boys. The boys looked to be 4 and 2 years old. Luckily, a good Samaritan had pulled over his RV and taken the boys out of the MVA into the RV so that we could work without the harsh conditions around us. I was in charge of airway, and as I'm bagging this patient, and he's going in and out of consciousness, in and out of convulsions, he had a large deformity to his upper left side of his head. I noticed that he had the exact same shoes as my 4-year-old who was at home. Now, I finished my job. I did exactly what I needed to do, remain professional on scene. We were able to package the patient, get him on a life flight to the children's hospital, but on the way back to the station, I couldn't help but fight back tears. Now, once I got back to the station, I called my wife on FaceTime, and mind you, my wife has seen me through most of my career. So I call her, tears welling up in my eyes, and I asked to speak to the boys. At this time, I had a 4-year-old and a 2-year-old at home, and she had never seen me like this. So quickly, she gave the phone to the boys, and of course, they don't know what's going on, and they're just asking me how my day's going. They're trying to show me a new toy they have, and I can only cry. My wife asked quickly, she asked me what was wrong, and I told her the story, and she says, "I've never seen you like this." And that was a trigger for me that I needed some sort of help. So I went to my battalion chief and told him what was going on. I was sent home for the rest of the shift, and I looked for counseling so that I could come back to the job and do it correctly. Now, that was many, many years ago, but I learned a lot from that lesson, and I still use it to this day. So, like that incident, there are many other critical events that can compromise individual resilience. Now, these could be accidents involving children, mass incidents like MCIs, major fires, death of a colleague, mistakes that injured or killed a colleague or bystander, traffic accidents, burn patients, violent incidents, murder scenes, making a death notification, or and exposure to AIDS or other diseases. What we need to understand that if the exposure to critical events and occupational conditions is enough, they have been linked to inflammatory activity and modification of the hypothalamic pituitary axis. You have to understand first responders experience many of these incidents on a regular basis. There's a significantly higher rate of mental health issues in first responders when compared to the general population because we are exposed to this day in and day out. If you look at this, you can see what we're exposed to: death, grief, injury, pain, and loss. Now, you couple that with demanding schedules, physically challenging jobs, and a lack of safety and security. What can this result in? It can result in emotional trauma, and then if we leave that untreated, it can lead to depression, anxiety, PTSD, suicidal ideation, and suicide. Now, what are some first responder mental health issues? Well, we deal with compassion fatigue, secondary trauma, depression, PTSD or post traumatic stress disorder, anxiety, substance abuse, and co occurring disorders. And we'll go into detail. Compassion fatigue. Now, this can occur due to exposure on one case, or it can be due to a cumulative level of trauma. It's generally marked by emotional exhaustion and withdrawal, associated with increased workload and institutional stress, emphasis on the increased workload. Cumulative compassion fatigue is not trauma related and it can happen to anyone in a caregiving role. It could even happen to family members giving care to an elderly family member or a sick family member. It's cumulative. Now, what are some symptoms of compassion fatigue? Well, chronic physical and emotional exhaustion, depersonalization of the patient, feeling of inequity toward the therapeutic or caregiver relationship, irritability, feelings of self contempt, difficulty sleeping, weight loss, and headaches. Secondary trauma. This is the emotional duress that results when an individual hears about the trauma firsthand from another person. Now, what can these symptoms include? Hypervigilance, hopelessness, inability to embrace complexity, anger and cynicism, sleeplessness, fear, chronic exhaustion, physical ailments, minimizing the guilt, and of course, depression. Post traumatic stress disorder or PTSD. This is characterized by exposure to actual or threatened death, serious injury, or sexual violence, either directly or indirectly. You'll have intrusive thoughts. Persistence avoidance of stimuli associated with the event. Negative alterations in cognitions and mood. Marked alterations in arousal and reactivity following a traumatic experience. In order to be diagnosed with PTSD, symptoms must last longer than 1 month, cause clinically significant distress in social or occupational functioning, not to be attributed to other conditions or substances. It is important to note that although a diagnosis of PTSD can only be given with symptoms lasting longer than 1 month, a person can seek professional help immediately following a traumatic event. Now remember that not all people experience the same PTSD symptoms. Matter of fact, the National Institute of Mental Health, the NIMH, has identified three types of PTSD: re experiencing, hyperarousal, and avoidance. When we talk about re experiencing, we're saying that it is characterized by nightmares and unexpected flashbacks of traumatic events that may include the same physiological responses, such as rapid breathing, sweating, increased heart rate. Hyperarousal. This is characterized by intense anger responses, insomnia, feeling on edge, and easily being startled. Avoidance. Now, this is characterized by feelings of guilt and depression, or having no feelings of any attachment at all. It can also be characterized by difficulty in remembering traumatic events, lack of interest in things that were once enjoyed, and avoidance of places that trigger memories of the experienced trauma. There are many symptoms included with PTSD. These are just a few, such as flashbacks, a physiological response. We discussed rapid breathing, sweating, increased heart rate, nightmares, negative alterations in cognitions and mood, difficulty remembering traumatic events, being easily startled, an intense anger response, sleep disorders, hypervigilance, and emotional numbness, avoidance of places, people, and activities that are reminders of the trauma. Let's look at these numbers. 80% of first responders report experiencing a traumatic event on the job. And in 2012, the prevalence rates of PTSD were 14.6% for emergency personnel. That's 7.3% for firefighters, 4.7% for police officers, and 13.5% for other rescue teams. Nearly 400,000 first responders in the United States alone and 10% worldwide are suffering from PTSD symptoms. Now, paramedics have the highest prevalence of PTSD. Police officers have the lowest, but there is likely significant underreporting in police officers. Paramedics respond to more emergencies than police and firefighters, yet they do not undergo the same intense screening. Since police officers carry weapons such as firearms, batons, electroshock weapons like tasers, the hiring process is designed to find individuals with personality traits related to psychological resilience through psychological assessment. But then we have other issues, anxiety being one. And anxiety is characterized by a feeling of uneasiness and worry, usually generalized and unfocused as an overreaction to a situation that is only subjectively seen as menacing. Now, these may include muscular tension, restlessness, fatigue, and problems concentrating. Fear and anxiety can be differentiated into four different domains. You could have the duration of the emotional response, a temporal focus, the specifics of the threat, and a motivated direction. Then we deal with field specific trauma. There are many traumas that are specific to first responders' field of work. Personal experience may include the experience such as being shot at, assaulted, threatened. If you're a firefighter EMT, the trauma of possibly being burnt, running out of air. Circumstances involving others may include exposure to sexually assaulted children, domestic violence, watching someone die, or even seeing mutilated remains. Trauma covered here is not comprehensive, and first responders will likely endure field specific trauma. Now, what may be traumatic for one person may not be for another, and it relates to that personal resiliency. First responders experience significant job related stressors and repeated exposures. These exposures may confer increased risk for mental health morbidities like PTSD, suicidal ideations, suicidal behaviors, or hasten mortality, death by suicide. Mental illness is a possible result of repeated exposures to critical events. Now, these repeated exposures can lead to suicide, or they can lead to the declining physical health and impaired decision making. Now, what could be some job related stressors? Well, there are many job related stressors that we endure, but here are just a few: increased risk, unpredictable hours, dual capacity work, access to lethal suicide means, and first responder demographics. And we're going to go into that. Increased risk. First responders' occupations carry distinctive risks that bear both significant and chronic dangers to one's health and safety. Police officers. Well, They shield the public from deadly bullets. Firefighters run into a burning building when everyone else is running out. And EMT paramedics are charged with saving someone from a life threatening situation. Beyond the potential for loss of life, these experiences may also lower one's fear of death, creating the conditions under which suicidality emerges. Unpredictable hours. How we all do shift work, and this will likely cause sleep disturbances and disruptions in family and social support, both of which are significant risk factors for suicide. Then we have dual capacity work. In dual capacity work, many first responders serve in more than one of these roles, such as a full time firefighter who is also certified as an EMT. It is likely that these additional occupational hazards may lead to an additional risk. Having the access to lethal suicide means some first responders often have access to highly lethal suicide means, such as firearms in the case of police officers. And then let's look at the demographic. First responder groups are overwhelmingly comprised of white males, the same demographic group that is already at a highest risk for suicide within the general population. Now let's get back to the statistics. Reports suggest a much higher than typical number in both previously attempted suicide and recent thoughts of suicide. A survey was taken and it found that more than 4,000 first responders found that 6.6% had attempted suicide. Now that is more than 10 times the rate in the general population. Another survey that was done found that 8% of first responders had recent thoughts of suicide. Let's look at EMT paramedics. Well, there are a few studies that evaluate suicide among EMTs and paramedics. Critical events that EMT and paramedics are exposed to have overlapped to critical events that both police officers and firefighters experience. And because EMTs and paramedics do not receive psychological training or screening that takes place in a police academy, it is expected that rates of suicide or suicidal ideations are very much similar. Let's look at this bar graph here. You could see that on the left side, you have the rate of suicide per 100,000 people. And then you could see the different occupations. You could see the total population, and then you could see how police officers and firefighters relate. The surveys were taken, and this is what we found. Let's look at firefighters. There's a rate of 38.5% higher chance than the general population of suicide, and only 40 to 45% of firefighter suicides are reported. If unreported estimates are accurate, and the actual number in 2017, suicides are approximately 257. Now, that is more than twice the number of firefighters who died in the line of duty. In police officers, there is a rate of 30.7% higher than the general population. Of 18,000 law enforcement agencies across the United States, only 3 to 5% have suicide prevention and training programs. Law enforcement suicides increased in 2019 by 24%. One thing we know is that PTSD is treatable. It is the most common mental health disorder experienced by first responders. And in this section, we will focus on the treatment that the disorder. However, it is important to note that any of these treatments have been found to be effective for other mental health issues and disorders that first responders may face. Recovery from PTSD and other mental health issues triggered by traumatic events is a gradual, ongoing process. Neither healing nor the effects of the trauma happen overnight. There are many steps that can be taken to cope with the residual symptoms and greatly reduce anxiety and fear that is experienced. So, a few things to consider in the treatment of trauma and mental health disorders that may be experienced by first responders. First, they are protective and resiliency factors that can be considered prior to traumatic experiences. Second, education on the treatment available is essential for those experiencing trauma and mental health disorders to know there are helpful options available. Third, it is important to know how to seek out mental health provider that is the right fit for you. And finally, researching state legislation in your area is vital to know what supports are available to first responders and yourself. Some states may recognize PTSD under workers' compensation for first responders, and some states may even give assistance available through the employers. Now remember, PTSD responds to a variety of effective treatments. All treatment should be supported by appropriate information and implemented by appropriate mental health professionals. So, how do we protect ourselves from trauma? Well, to protect ourselves is to be resilient. To have resilience is to have a sense of community, where you have feelings of belonging and emotional attachment. There can be a collective efficacy. Now, this is perception of the group's ability to accomplish its major task, and a first responder's jobs are highly collaborative in nature. Protective and resilient factors against trauma. You have a sense of community. These are feelings of belonging and emotional attachment. Collective efficacy. Perception of the group's ability to accomplish its major tasks. First responders' jobs are highly collaborative in nature, so this shouldn't be hard. Then you also have self efficacy. This is the ability to exercise some measure of control over your environment. Positive coping strategies. This is the ability to manage stress constructively, such as using approaches like cognitive behavioral therapy or CBT. Compassion, satisfaction. These are positive feelings from helping others. You want to incorporate the positive aspects of trauma situations to achieve good outcomes. Have post traumatic growth, post crisis treatments, and interventions. These are some of the tools that we have after we've been through a traumatic event. Critical incident stress debriefing, CISD. Cognitive behavioral therapy, CBT. Eye movement and desensitization and reprocessing, EMDR. Prolonged exposure therapy. Brief eclectic psychotherapy. Dialectical behavioral therapy, or DBT. And of course, pharmacotherapy. In a CISD, or critical incident stress debriefing, this is a type of group debriefing that takes place following exposure to a potentially traumatic event. It has 7 stages toward the protocol, and these include introduction, facts, thoughts, reactions, symptoms, education, and then, of course, reentry. CISD was developed as part of a program called the CISM, or Critical Incident Stress Management, CISM. CISM includes an individual counseling, pre exposure interventions, family support, and referral for further therapy. Cognitive behavioral therapy. CBT is based on a few core principles. These include psychological problems are based in part on faulty or unhelpful ways of thinking, or psychological problems are based in part on learned patterns of unhelpful behavior. People suffering can learn better ways of coping and how to relieve the symptoms. CBT treatment involves efforts to change thinking patterns that are creating the problem. Now, these treatment strategies can include learn to recognize thinking errors and reevaluate them, gain a better understanding of the behavior and motivation of others, use problem solving skills to cope with difficult situations, and develop a greater sense of confidence in a patient's abilities. CBT treatment usually involves efforts to change behavioral patterns. Strategies may include for the patient to face and evaluating fear rather than avoiding it, prepare for potential problematic interactions with others through role playing, learn to calm the mind and relax the body. CBT focuses on helping patients learn strategies to be their own therapist through exercises and sessions with therapists and homework. Coping skills can learn to change one's own thinking errors, help them to cope with problematic emotions, and change the behavior. As we go into EMDR, or eye movement and desensitization and reprocessing, this is an interactive psychotherapy technique that focuses on the memory of a traumatic event. The structure follows an 8-phase process. 1. History taking. 2. Preparing the client. 3. Assessing that target memory. And through 4 through 7, we process the memory to adapt a solution. In phase 8, we evaluate the treatment and see if it's working. EMDR therapy has proven to be effective in treating trauma and PTSD. It may also be able to help treat other mental conditions like anxiety, depressions, and panic disorders. Now, some people may actually prefer EMDR treatment to prescription medications because some prescription medications may have unexpected side effects. Others may find that EMDR therapy strengthens the effectiveness of their medications. EMDR has been found to be more effective at treating PTSD among first responders than a stress management program. We have prolonged exposure therapy, or PE. Now, what does this do? This teaches patients to learn how to gradually address traumatic memories. Now, the goal of PE is to help the individual facing the trauma to stop avoiding the memories. Those suffering from avoidant PTSD may have the most success with this type of therapy. Now, the American Psychological Association, or APA, strongly recommends PE for treating PTSD. In a study of police officers, treatment of PTSD using PE led to PTSD remission. Core components of exposure programs are imaginal exposure, revisiting the traumatic memory, repeatedly recounting it out loud, and then processing the revisited experience. In vivo exposure, this is the repeated confrontation with situations and objects that have caused the distress but are not inherently dangerous. Now, what is the goal? The goal is to promote processing of the trauma memory, also to reduce distress and avoidance evoked by the trauma reminders. Now, mental health professionals currently use PE to treat a multitude of traumas. Now, these traumas may include rape or assault, child abuse, combat, motor vehicle accidents, or disasters. Prolonged exposure has been proven beneficial for patients suffering from co occurring issues of PTSD and substance abuse when combined with substance abuse treatment. Randomized controlled trial studies exist in which have indicated that there are little to no negative effects of using PE for patients with substance abuse disorders. Brief eclectic psychotherapy. This is a short term form of psychotherapy using an eclectic approach. Generally consists of a combination of cognitive behavioral and psychodynamic approaches over a limited number of sessions, usually less than 16. This focuses specifically on reducing feelings of guilt and shame. Now, following treatment of BEP, 86% of first responders with PTSD return to work. Dialectical behavior therapy, or DBT. This is evidence based psychotherapy used to treat borderline personality disorder, or also known as emotionally instability disorder. The evidence exists that DBT can be useful in treating many mental health issues, including mood disorders and suicidal ideations. DBT can help change behavioral patterns such as self harm, eating disorders, and substance abuse. Most helpful in treating first responders experiencing suicidal ideation, substance abuse, PTSD, and other mental health disorders. Then we have our pharmacotherapy, our medications. Many medications are definitely beneficial in the treatment of PTSD, and the most common ones we use are selective serotonin reuptake inhibitors, or SSRIs, and benzodiazepine. Now remember, very important fact here, benzodiazepines are not recommended as a treatment method for PTSD on their own because they have been observed to increase early incidence of PTSD after treatment. They'll have worsening symptoms during withdrawal and may have a likelihood of developing dependence. Now, like with anything that is new, there are barriers. And as we delve into the mental health issues, we have barriers. Some of the barriers we see are receiving mental health care. Also, many barriers and stigma experiences are subsiding with public education on mental health issues. Barriers to treatment. Barriers to receiving mental health care are not uncommon in general population. Because mental health is a new issue, and by new I mean it is finally being brought to the forefront, we are seeing many barriers. Barriers such as stigma, but those stigma are subsiding with public education on mental health issues. But as first responders, we may face an additional and a unique challenge when we seek treatment. In a review of studies assessing barriers to care among first responders, 33.1% of participants reported experiencing some barrier to receiving treatment for PTSD. Now, what could be some of those barriers? Well, these barriers could be many things. Here are the most common: difficult schedules, inability to take time off work, confidentiality concerns, unsure of where to seek help, and here's the large one: fear of a negative impact on a career. These are the barriers that keep us quiet when in fact we need help. Now, left untreated, these barriers will lead to PTSD. One study noted that people diagnosed with PTSD fairly soon after developing symptoms typically have a significantly higher chance of spontaneous recovery than those diagnosed after exhibiting symptoms for extended amounts of time. There is a possibility a person can naturally recover from PTSD. but there's no prediction of who will be able to do that and who won't be. All affected individuals should seek prompt treatment from qualified mental health professionals. Understand the problem will not just go away. Key topic: PTSD is treatable, very treatable. In the process of healing from trauma, many people may discover strengths they didn't know they had or find a support network they didn't know was there. Other people may find that treatment helps them develop new insights into life and how to cope with other problems they may face. But how do we find the best therapist for us? Well, there's a multitude of ways. Shop online. Is there a gender of therapist that you are looking to converse with? Theoretical orientation. And ask lots and lots of questions before starting treatment. When I say shop online, this is a benefit to us because it's an easy way to learn about the therapist in your area. It's important to see what kind of advertising therapists use to seek out patients. Now, a good therapist uses the ad to tell about their experiences, their work, and their philosophy of working with patients. Now, this is a very easy and low risk way to see if the person will be a good fit for you and your treatment. When we discuss gender, most people have an immediate idea of what gender of person they would prefer to work with. It is clinically valuable to notice what preferences you have before starting treatment with a therapist. Theoretical orientation. What this does is it provides a foundation for treatment planning and interventions that will be used. Understanding of theoretical orientation can establish guidelines or expectations of the approach, the area of expertise, and the services to the clients that this therapist may have. It's important for both the counselor and the client to understand these expectations. Every mind is different, and every person will respond differently to different forms of therapy. Remember, when out there looking for a therapist to serve you, you have to ask a lot of questions. You have to ensure that this therapist will be the right fit for you to help you with your needs, and getting well is the ultimate goal. Questions such as: are you a licensed psychologist? And how many years have you been practicing? Tell them what you've been feeling and the problems you have, and ask them what kind of experiences they have dealing with those issues. Ask about areas of expertise. Ask what kind of treatments they use. Ask them about their training. Could they be licensed? Could they have just taken a 3-hour online course? Or can they have taken months long courses on certain topics? Ask them about their fees. Ask them if there's a sliding scale for their fees. And ask what type of insurance they accept. These are all great questions to see if this therapist will be the right fit for you. One thing we also know is that PTSD typically does not go away on its own. Like we stated before, some people may have the ability to resolve it on its own, but some may not. Without treatment, symptoms can last for months to years. And even with a successful treatment, symptoms may come and go in waves. So you may have a relapse, and that's okay. It's expected. Healing from a trauma, a mental health disorder, or any other issue that may arise from critical events encountered in the career of a first responder is not a one time event. We deal with it over and over and over again. And when that issue is not properly treated, long term effects accompanied by PTSD have potential to cause significant impairment. If left untreated, PTSD places a person at a much higher risk of developing other mental health disorders and medical illnesses. Treatment should be sought immediately whenever needed. And even if a person feels they have already moved past their issues, they may still need treatment. Knowing that symptoms can come in waves gives a person knowledge and power to seek treatment whenever necessary. So many long term problems that may develop or worsen with PTSD that's been untreated include this laundry list. But let's look at the real important ones: self harm, suicide ideations, suicide attempts, and suicide. A lot of the other issues will lead to those. This is just a laundry list of issues to illustrate how important it is to treat any and all PTSD symptoms. Now, in conclusion, as first responders, we experience critical events at both a much higher amount and frequency than the general public. And now, this can lead to poor mental health and emotional trauma. And when trauma isn't treated, what can it lead to? It can lead to a multitude of symptoms that can lead us to PTSD or many other mental health conditions, such as depression, anxiety, suicidal ideations, sadly, suicide. But there is hope. Understand these situations are treatable. And it is critical that first responders understand the importance of treating these conditions as quickly as possible. This course was intended to add to your knowledge of first responders' common exposures to critical events and resulting trauma so that you can identify critical events, self assess stressors and symptoms of issues that you may be facing or that you may witness an employee or coworker facing. Determine the appropriate management and disposition for yourself to treat any conditions that you may face as a result of this exposure. Now, this course attempted to provide you with the information that will assist you in being aware of mental health conditions that first responders that we face and ultimately allow you to provide an even higher level of care to those that you serve and those who you work with. I want to thank you all for signing into this course. It has been an honor to discuss these issues with you. Thanks again for signing into this course. I'm your instructor, Rick Campos, and remember, you are your best advocate.